Good afternoon, everyone, and thank you for joining us for the third session of the 2023 Older Adults and Opioids webinar series, hosted by the Finger Lakes Geriatric Education Center, a HRSA-funded geriatric workforce enhancement program at the University of Rochester, and our co-sponsor, the Western New York Rural Area Health Education Center, who are also a HRSA-funded education center. My name is Laura Robinson, and I am the program coordinator for the FLGEC. My co-host is Christine Chappell, and she is the administrative coordinator at the Western New York Rural AHEC. And we are very glad you could join us for our third year of hosting this series. We have just one housekeeping item for you today. Please use the chat button to type hello and introduce yourself with a name, job title, agency, location, whatever information you would like to share with us. But share a lot if you are looking for CME or social work credit, please. That way we make sure we mark you for attendance. And we have people across the country and the world joining us today. So welcome to people from all across New York State. And we have viewers in North Dakota and South Africa. So thank you for joining us here today. So again, please introduce yourself, especially if your Zoom name does not match your real name. You know who you are, iPhone and Samsung. We can only provide CME and social work credits to real people. Thank you. Our featured speaker today. Oh, wait, before I do that, let me go through these slides. I'm jumping way ahead. So our slides, here is our title. Here are our learning objectives. Speaking of CME and social work credits, we have no relevant disclosures on either the planning committee or our presenter today. If you do want to claim CME or social work credits, here is the link. I will email this link to you with instructions following the webinar. There is a typo on this slide. April 8th has passed already, so try May 8th. They should be uploaded by May 8th. Into our system. Usually they're pretty quick, but sometimes there's a delay or a glitch. So just email me if you don't get your credits by that date. And there was no commercial funding received to support this activity. All of this activity is supported by grants from HRSA. So now I'm going to stop sharing and invite our presenter to share her slides, please, while I do her introduction. So today, our featured speaker is Dr. Alexa Melucci, and Dr. Melucci is a general surgery resident at the University of Rochester in Rochester, New York. She received her undergraduate and medical degrees from the Pennsylvania State University and Rutgers Robert Wood Johnson Medical School. Dr. Melucci considers herself a lifelong learner and has recently obtained a master's in health professions education from the University of Rochester Warner School of Education. She is currently focusing her research on disparities in the perioperative care of older adults on her path to obtaining a master's in epidemiology from the School of Medicine and Dentistry, also at the University of Rochester. Dr. Melucci has worked closely alongside her mentor, Dr. Jacob Maluem, to help lead post-surgical opioid reduction efforts within the Department of Surgery at the University of Rochester, and has several peer-reviewed publications in the opioid literature, which is where I found her to do this webinar. So whenever you are ready, Dr. Melucci, please take it away. Thank you so much for being here.
Great. Thank you so much, Laura. Just want to confirm, since we were having some technical difficulties, you guys can hear me. And my PowerPoint is just showing you the slides and not the presenter view, right?
Yes, to both.
Perfect. Okay. So hello, everybody. Thank you so much, Laura, for that really nice introduction. My name is Alexa Melucci, and I'm a surgery resident and a clinical research fellow at the University of Rochester. And on behalf of the University of Rochester and the authors, I'd like to thank the Monroe County Department of Public Health and Lifespan and the Finger Lakes Geriatric Education Center at the University of Rochester for the opportunity to present our work at this year's 2023 Older Adults and Opioids webinar series. The relevant author disclosures are listed here. They've updated a bit since we've done some paperwork with Laura. I am one of the co-investigators and recipients of the University of Rochester Faculty Medical Group Healthcare Innovation Pilot Awards for an opioid reduction project in the Department of Surgery. Additionally, these data that we'll discuss later on were published in the Journal of the American Medical Directors Association in April of last year. So first, we'll start by discussing the opioid epidemic as it pertains in the surgical world, followed by the aging surgical population with cancer, which will then lead nicely into our study. And then we'll conclude with some implications from our study and future directions. And so the opioid epidemic was declared a public health crisis by the president in 2017. And I think at this point, we unfortunately know all too well about this crisis. This slide outlines statistics many of us are likely familiar with. I will take the time to highlight the last bullet, that 50 to 85% of heroin users began by abusing prescription opioids, first either from their own prescription or through diversion of a prescription. And this is important as later on we'll focus on prescription opioids after surgery, highlighting the fact that no prescription comes without a risk to the patient or others in the community. And here the slide shows the death toll from this epidemic. In the figure on the left, we see the number of overdose deaths involving any opioid, and they continue to climb thanks to the highly potent fentanyl analogs. And in the figure on the right, we see the overdose deaths from prescription opioids. And we see that they actually peak in 2020 and then start to downtrend. And it's unclear if this favorable trajectory will continue, but it's nice to think that with increased knowledge and awareness on overprescription and a newfound emphasis on opioid reduction, especially after surgery, there may be hope that this positive trend could continue. The opioid epidemic in surgery has been a hot topic for the last few years. So how did we get here? In the 1990s, there was increased pressure to manage both chronic and acute pain. And in 1996, the American Pain Society adopted the phrase, quote unquote, pain as the fifth vital sign. And this was then incorporated into the Joint Commission's standards in 2001. And so this high demand for pain medications then promoted pill mills, where massive amounts of pain medications were prescribed without really any patient-physician relationship. And so now, opioids are continued to be prescribed after both major and even minor surgical procedures. And often a patient's first exposure to opioids is following surgery. And so investigation into opioid use after surgery has demonstrated, as we'll discuss using a few study examples, significant overprescription, which is fueling this epidemic in the surgery world. And I think before we talk about some of the studies, we should reference and talk about one of the leaders in investigating the surgical opioid epidemic, and that's the University of Michigan. And they had created this Michigan Open, which stands for Michigan Open Prescribing Engagement Network. And it was founded in 2016. And this is an educational, research, and policy collaboration that helped us understand opioid use and opioid need after surgery, and has actually helped drive true policy change. So this is one study that I wanted to highlight from this Michigan group. And it looks at opioid naive patients after routine inguinal hernia repairs. And they found that 1.5% of these patients developed new persistent opioid use after this routine procedure. So these were patients that were not taking opioids prior, went in and had a routine procedure, outpatient procedure, and some of them developed persistent use after that. They found that the biggest risk factor for developing this new persistent use was actually receiving a preoperative opioid prescription, which suggests the role for preconditioning. This is another study from Michigan that looked at the other extreme, so following cardiothoracic surgery procedures. 13% of opioid naive patients had persistent opioid requirements 180 days postoperatively. And the likelihood of persistent opioid use was directly proportional to the size of the initial prescription. So if we look here in this graph, on the x-axis, we see quartiles of prescription size. OME stands for oral morphine equivalents. And on the y-axis, we see the adjusted persistent use in percentage. And as we increase the prescription size, we see the percentage of patients who become new users increases. And this is another phenomenal study from that same group at Michigan, and it was published in JAMA Surgery. Here, they compared postoperative opioid prescriptions with patient-reported opioid consumption, and they demonstrated a very consistent pattern of overprescription. Additionally, they found that far more than postoperative pain scores or any other variable, the most important predictor of how many pills a patient took after surgery was, again, the size of the prescription they were discharged with, demonstrating that we as surgeons and providers, any patient providers, can precondition our patients to anticipate pain and then anticipate the need for strong medications to treat it. So this figure shows the most common procedures that they included. The light green is the median pills consumed, so the patient consumption data, and the dark green is the median pills prescribed. So just taking a look at the contrast of the bars, you can see that more pills were prescribed than consumed. And in this study, they found that about fewer than 50% of the pills prescribed were actually consumed, and only 22% of the patients consumed their entire prescription. And this figure, again, is similar to the figure in the prior slide, where it shows the mean and the range amount of the opioids prescribed, and then the amount of opioids consumed on the y-axis. And so as you can see, as the prescription size prescribed increases, then the amount consumed also increases. And so Michigan Open and Michigan, among other institutions who are doing work in this realm, have helped us understand three major takeaways on opioid prescribing after surgery. The first is becoming a new chronic opioid user is the most common post-surgical complication. The second is prescribing of opioids often far exceeds the pain management needs of the patient. And three, prescription size is the strongest predictor of how much opioid a person will consume. And so these highlight the significant influence and the important role that surgeons, physicians, advanced practice providers, social workers, really anybody who has touch with the patient in the hospital, out of the hospital, can have on patients and the opioid epidemic in surgery. So then I think the next question to ask, well, is this just a problem in the United States or is it a problem around the world? And this was a really nice study done by Carafani et al. And they looked at 4,700 patients who underwent general surgery procedures. So a removal of the appendix, a removal of the gallbladder, and again, inguinal hernia repair. And they looked at these procedures across 14 large academic medical centers around the globe. The three in the United States were Harvard, Johns Hopkins, and the University of Arizona in Tucson. And unfortunately, they found that unequivocally, this prescription opioid problem was uniquely an American problem. And they give some insight into why. So on this graph, we can see the median for US and the median for non-US number of pills at discharge. And so while the median and average discharge number of pills after these common operations was actually less than 5 for the non-US academic centers, everywhere else in the world, the American patients were being discharged with an average of 25 pills. Equally disturbing is the fact that American patients reported an average pain score of 4 at discharge from the hospital, whereas similar patients across the world who received far less opioids while in the hospital rated their pain as a 1. And so these data suggest there is definitely work to be done in the United States to address this problem. And so We just learned that prescription opioids after surgery appears to be a uniquely American problem. And in order to better serve our patients and to address this issue, it's important to know who our patients are. And I think it's really important to understand that the landscape of the United States population is changing. By 2034, for the first time in history, older adults are projected to outnumber children, making up 23.4% of the population. And so it's crucial to recognize and adapt to this shift so that we can prepare for the needed expertise and resources to take care of this aging nation. Even more striking, within a decade, 70% of cancer will occur in adults 65 years and older. And this is a graph from the Surveillance, Epidemiology, and End Result, or SEER program. And they used 18 SEER cancer registries to plot the average annual incident rates of cancer cases. And so this graph demonstrates that overall cancer risk increases with age, and it actually peaks in 80-year-olds. These data suggest that not only are we projected to take care of an aging population, but an aging population with cancer. And so with continued research and the evolution of cancer treatments, patients are living longer, and therefore more of them are undergoing major surgical procedures for cancer. Roughly 40% of inpatient operations are performed on older adults. And not surprisingly, these older patients have 2 times the postoperative morbidity and mortality rates compared with younger adults. And this is attributed to everything that we think of with an older adult. So the increased comorbidity burden, their impaired functional status, decreased physiologic reserve, and polypharmacy, as well as the changes in pharmacodynamics and kinetics with aging. And geriatric syndromes such as delirium, functional decline, and falls, just to name a few, are common postoperative complications for older adults in general. Notably, 1 in 6 older adults will develop postoperative delirium after major inpatient surgery. And while enhanced recovery after surgery pathways, or ERAS pathways as we call them in surgery, and an emphasis on sleep hygiene have helped to mitigate these risks, they still remain high. And so given older patients' increasing age, their physiologic decline, the extensive medication regimens, older adults have increased opioid sensitivity. And then this sensitivity can perpetuate the cycle of developing these age-related postoperative complications. The prior studies that we highlighted demonstrate that patients generally across the board are being prescribed a large amount of opioids after surgery. To date, there are a few studies analyzing opioid use and opioid prescribing patterns for older adults after surgery. And here, this slide highlights a few of them. One study in patients who underwent elective spine surgery found that a small proportion of older adults developed chronic continuous opioid use. In the orthopedic surgery world, there was a study in older adults after orthopedic procedures, and it demonstrated that the youngest old patients, so those aged 65 to 79, used more opioids compared to the oldest old patients, those aged 80 years or older. Another important study in this population looked at the effect of NSAID use, so ibuprofen or Toradol, and the effect that it had on opioid requirements. Providers are often weary to use NSAIDs in older adults due to the increased risk of bleeding, kidney injury, and medication interactions. But this study found that the use of NSAIDs decreased opioid requirements without increasing the risk of bleeding or the need for a higher level of care, suggesting it could be safely used in select older patients. And finally, a study in older adults after cardiothoracic procedures found that, again, size and preoperative opioid prescription were the strongest predictors of new and persistent opioid use. And so taken together, these data echo the findings that we previously discussed in the opioid literature, that older adults are also at risk for persistent opioid use, and that preoperative prescriptions and discharge prescription size are important risk factors. And so while these prior studies that we just discussed provide important information on opioid use in older adults, there still remains a paucity of information on opioid use in older adults after major surgery for cancer. Given that patients with cancer represent a substantial population of patients receiving opioids, and the majority of patients with cancer are older adults, investigating patterns of opioid use in this challenging population is a priority. Therefore, our study aimed to analyze and compare postoperative patterns of opioid use and discharge opioid prescriptions in older and younger patients after oncologic resection or resection for cancer. We hypothesized that older adults would require fewer opioids in the postoperative period and at discharge when we compared to their younger counterparts. So we conducted a retrospective cohort study of a prospectively maintained database at our tertiary care center for the 2019 calendar year. We included adult patients with tumors of the lung, breast, pancreas, colon, rectum, and skin who underwent elective surgery for cancer. We excluded any patients who had an aborted procedure, those without cancer on pathologic review, and chronic opioid users, which we defined based on prior literature definitions as an opioid prescription within 90 days of the procedure or active use of Suboxone. From an epidemiologic perspective, our exposure was age. So we were more interested in older adults who were age 65 years or older. Opioid use is commonly described in the literature as the number of morphine equivalents or oral morphine equivalents, as we've seen in the previous studies. And so here we've abbreviated it as morphine equivalents. When we present our results, I will present them as morphine equivalents, but I'll also convert them to the number of oxycodone pills, just for an easier way to kind of understand and compare between older and younger patients. The study outcomes included patterns of inpatient and discharge morphine equivalents, factors associated with discharge prescription, and opioid refill requests. Among 676 patients who had suspicious or confirmed neoplasms of the included sites and underwent elective surgery, 445 patients met our inclusion criteria. This table outlines the characteristics of the total cohort in the first column, the younger and the older adult populations in the second and third columns. The median age of the total cohort was 66 years. The majority were female and non-Hispanic white. They had resection for lung cancer and overall had pathologic stage 1 cancers. The older adults had a median age of 73 years. The majority were also female and non-Hispanic white. A larger proportion of the older adult patients were discharged to a home health organization or skilled nursing facility compared to younger patients, which makes sense. The majority of older patients had a resection of the lung and lung cancer, while younger patients had resection of the lung and colorectal cancer, likely representing colorectal metastases. Older adults were more likely, older adults were more likely to be prescribed inpatient non-opioid medications, but they were equally likely to be discharged with non-opioid medications. Despite older adults having a longer length of stay, a median of 3 versus 2 days, they consumed less than half of the opioids than their younger counterparts postoperatively. They consumed a median of 5 pills compared to a median of 11 pills. And this first figure demonstrates the average pain score in the final 48 hours. The inpatient opioid use we are presenting, we have good information from our database on what patients have used in the final 48 hours from discharge. And there are some institutions that use this as kind of a benchmark to figure out what patients should be sent home with. So this is one of the reasons we included this in our analyses. And so compared to younger adults, older adults had significantly lower pain scores, 1 out of 10 versus 3 out of 10 in the final 48 hours prior to discharge. And similarly, this graph on the right demonstrates the opioid use during the same time, so the 48 hours prior to discharge. And older adults consume significantly less opioids, 15.3 milligrams versus 77.4 milligrams. So converting that to pills, it's 2 pills compared to 10 pills. Stratifying by age, older adults reported progressively lower pain scores and had progressively lower opioid use in the final 48 hours of admission, and both of these were statistically significant. And so then when looking at opioid prescriptions at discharge, older adults had a lower median discharge prescription, so lower median discharge morphine equivalents than younger adults, 75 milligrams compared to 112.5 milligrams. And if we convert this to pills, the older adults were going home with 5 less pills than the younger adults, so 15 and 10. We then did an analysis of refill requests, and we found that older adults called less often for a refill than younger adults. 6.5% of older adults called for a refill compared to 14.5% of older adults. Again, if we stratify these data by older age groups, increasingly older adults had progressively lower median discharge morphine equivalents. And so here we can see, again, the younger adults went home with 15 pills. The 65 to 74-year-olds went home with a median of 12. 75 to 84 went home with a median of 7. And 85 and older went home with a median of 0 or no opioid pills. And similarly, older age groups had progressively lower refill requests. We performed a multivariate analysis to identify factors that were independently associated with discharge morphine equivalents. This identified that age, specifically the 85 and older, as well as the cancer type compared to skin and soft tissue, normalized postoperative morphine equivalents in the final 48 hours, so what patients were consuming 48 hours prior to discharge, and the average final 48-hour pain score were significant predictors of discharge morphine equivalents. We also performed a sub-analysis on patients who consumed no opioids prior to discharge. So in that 48-hour time period prior to discharge, 47% of older adults consumed no opioids, and 31% of younger adults consumed no opioids. And among those patients who did not consume opioids prior to discharge, still 52%, or more than half of these adults, and 63% of younger adults were sent home with an opioid prescription. And so this represents low-hanging fruit for opioid reduction initiatives, because these patients aren't actively taking opioid pills in the hospital, yet they're still being sent home with them. And so the study conclusions, there were a few that we had come up with. The first is that older adults after resection for cancer, they report significantly less pain and consume significantly less opioids in the hospital than younger patients. We found that older adults were discharged with significantly less opioid medication, and they requested refills less often than their younger counterparts. And that these findings were age-related, with less pain being reported and less opioids being consumed with increasing age. However, we unfortunately did find that there still remains opportunity to decrease unnecessary opioid pills, as we demonstrated that there are patients who weren't taking opioids just prior to discharge, but a good proportion of them were still being sent home with them. And so while this study is the first to compare opioid use among older and younger adults after cancer surgery, our results should be interpreted in the context of some limitations. The first is that this is a retrospective study of a single institution. And so the study was limited to the data that we had available, and it may not be generalizable to other smaller non-academic centers. And while we had information on pain scores and opioid consumption in the final 48 hours prior to discharge, data on post-discharge opioid consumption, like we talked about in the Michigan studies, unfortunately was not available. We present information on refill requests, and these refills are noted within our electronic medical record. And so while the majority of patients receive care within our system, there are patients that do receive care outside of our system, and we don't have access to this information on refills that would have occurred outside our system. And finally, while enhanced recovery after surgery or the ERAS pathways are implemented in some divisions, none at our institution during this study period have adopted age-specific recommendations, and therefore we did not feel influenced our results. So our results demonstrated that older adults use significantly less opioid medication in the postoperative period and prior to discharge, and that generally they were sent home with significantly less pills than their younger counterparts. So when thinking about implementing a postoperative reduction pathway, a one-size-fits-all approach to opioid prescriptions would lead to a dramatic overprescription for older adults. And this has important implications because older adults are not immune to opioid misuse. And in fact, opioid misuse is increasing among older adults. And the current statistics from the Centers for Medicare and Medicaid Services suggest that Medicare beneficiaries have among the fastest growing rates of opioid use disorder. Another study found that emergency room visits for opioid use in older adults has actually increased by 220%. And that drug overdose deaths in this age group also increased from 2.4 to 8.8 deaths per 100,000 older adults. Current studies also suggest that similar to opioid use disparities in the general population, that there are sex and race and ethnicity disparities that exist among opioid use deaths in older adults. However, continued research in this area is warranted. It's important to understand that postoperative pain is not the same as chronic cancer pain in older adults. Our study demonstrated after surgery for cancer, the majority of older adults are sent with few or no opioids and don't call for refills, suggesting a small number of opioids, if any at all, are adequate to treat postoperative pain. This finding is especially important for providers at skilled nursing facilities and rehabilitation centers, as these facilities take care of a large number of these patients. And they also may expect that these patients come to their facilities with an opioid prescription. However, these older postoperative patients have different needs than patients with chronic cancer pain who may be admitted for other reasons. Social workers who do all the heavy lifting in the transitions of care for these patients should also be aware of this finding and can help us normalize opioid-free discharge for these patients. Older adults should not be sent with an opioid prescription just in case. And in fact, as we've highlighted, among the 115 older adults who didn't consume opioids prior to discharge, the majority, 52% of them, were still sent with an opioid prescription. And so this represents, as we discussed, an area for further improvement. Older adults are more sensitive to opioid medications, and such use can precipitate complications, as we discussed. Best practice guidelines highlight the importance and the necessity of opioid-sparing multimodal pain regimens. Treating pain in the older adult is challenging, as if we don't adequately treat it, uncontrolled pain itself is a risk factor for developing postoperative delirium. So one may view this as, a delicate balancing act. We're trying to limit the risk of opioid sensitivity and postoperative complications, but also adequately treating pain so that we can also limit postoperative complications. So there are pharmacologic and non-pharmacologic pain control strategies. And the first-line pharmacologic options for pain control include non-opioid medications, such as acetaminophen or Tylenol, and NSAIDs like ibuprofen and Toradol, which can be carefully used in the older adult populations. Surgeons should also discuss with their anesthesia team about the potential use of regional anesthesia, such as nerve blocks. Transdermal pain patches are also a great topical option with minimal risk. Non-pharmacologic options include heat or ice, depending upon the type of surgery they have, and alternative therapies, which are becoming more common, like meditation and music therapy. And so, recognizing the unique needs of older adults undergoing surgery, national surgical organizations are looking to improve the current surgical standards for these patients. The American College of Surgeons, the largest surgical organization in the world, established the Geriatric Surgery Verification Program in 2019. And this nationwide effort intends to improve surgical care in the older adults by emphasizing preoperative screening, establishing care plans for older adults at risk for age-related complications, and providing postoperative recommendations. Among these care plans actually include the recommendation for perioperative opioid-sparing multimodal pain regimens. And over on the right hand is what the Geriatric Verification Program lists in their current standards. So it's clear that the number of older adults and those with cancer will be taken care of as a multidisciplinary team after major surgery is increasing. And so institutions should look to adapt and to institute an older adult specific postoperative pain management pathway. And to do this, they should look to utilize national resources, one being the American College of Surgeons Geriatric Verification Program guidelines. However, they should look to further tailor their recommendations to those that may work within the confines of their institutions, as we know that institutions vary and resource availability also varies. So finding ways to streamline screening and implementation of these recommendations through use of the electronic medical record may be the way of the future and the way of patient-centered care for this population. I want to thank you again for the opportunity to present our work, and I'd be happy with the time remaining to take any questions.
Thank you so much, Alexa. That was quite comprehensive and very shocking in a couple parts, especially the stats about around the world.
Of course.
Oh my gosh. If you want to take your screen down, we can see everyone. I will stop recording as well.